Good evening, everyone, and a very, very happy new year. Welcome to the 62nd lecture and the first lecture of iFocus on the year 2021. It's my great pleasure to welcome Dr. Sayan Basu today, who will be talking about the tips and tricks of ocular surface reconstruction. Dr. Sayan Basu received his clinical training in cornea and ocular surface from LVPI and his research training in stem cell biology from University of Pittsburgh in USA. He's a prolific corneal transplantation and cataract surgeon, internationally recognized for his innovative breakthroughs in stem cell therapy and keratoprosthesis. Dr. Basu has received the Achievement Award from American Academy of Ophthalmology and serves on the editorial board of several eminent journals. He has published numerous highly cited papers. Currently, he's developing a state of the art dry eye clinic, producing 3D printed corneas and developing novel stem cell therapies with renowned national and international collaborations. Dr. Basu currently heads Professor Brian Holden Eye Research Center and Center for Ocular Regeneration at LVPI. Welcome, sir. I'll hand over the lecture to you.
Thank you so much, Mitika, for the very generous and kind introduction. And I also want to thank the organizers, particularly Dr. Honavar, for inviting me to give this talk. And he asked me to speak on ocular surface reconstruction, which is a very interesting but very rarely discussed in detail kind of topic. And I hope that I'll be able to touch all the relevant aspects to cover this topic. And I'll be very happy to take any questions from those people who are listening to this live or those people who want to reach out to me later if they have any doubts. And I just want to begin by wishing all of you a very, very happy, productive, and healthy new year 2021. Please stay safe, stay healthy, and I hope that it turns out much better than the nightmare we had last year. So, ocular surface reconstruction tips. I'll begin by an algorithm for the surgical management of limbal stem cell deficiency, because when we speak about ocular surface disorders, ocular surface disease dysfunction, the main cause of ocular surface problems worldwide and particularly in our country is limbal stem cell deficiency. So this is the algorithm that we follow at the LV Prasad Eye Institute, and I think it's a very intuitive kind of a stepwise algorithm which helps you decide, particularly to decide on which surgical option you're going to choose for the patient. So it basically, you divide all your patients between whether they have a unilateral problem or a bilateral problem. And amongst those patients who have a unilateral problem, you look at whether they have visual potential or not. Okay. And then you look for the dryness or wetness of the surface. So even within unilateral LSCD, therefore, you will have patients who may not have visual potential in that eye, may have a wet surface or a dry surface. Now, if there is visual potential and the surface is wet, now, of course, you assess wetness of the surface by doing something as simple as doing a Shermer's test to assess that, or you can just look for the luster on the surface of the eye. Sometimes patients may have dryness, but maybe putting lubricant drops very frequently. So that's a caveat. You need to watch out for that, and you don't get a false positive. But otherwise, if you have signs like keratinization on the ocular surface, etc., it pretty much is a giveaway. Like you can see in the photograph in the bottom, it's pretty much a dead giveaway that this is a dry surface, and therefore easy to differentiate between these two. But like I said, in subtle cases, just be careful in measuring your Shermer's. You might want to repeat it once to check the extent of wetness. Now, if it is unilateral, visual potential is present and it's a wet surface, then it's very straightforward. You attempt an autologous limbal stem cell transplant procedure with or without a conjunctival autograft. And typically, you do not try to combine this or make this too complicated by combining this with a corneal transplant, whether penetrating or lamellar. You just do the limbal stem cell transplantation and take a call on the to clear the corneal stroma later on. Most cases, and I'll show you this later on, with successful stem cell transplantation, usually the corneal stroma will clear or get more transparent with time. If, on the other hand, it's a dry surface or there is no visual potential, then we usually will give the patient a cosmetic option like a contact lens or a prosthesis to wear. We will typically not intervene in these eyes, particularly if they're dry, because limbal stem cell transplantation, like any other tissue transplantation, will not work in a hostile environment. Now, on the ocular surface, a dry surface is an hostile environment. So you can't do a tissue graft and get away with it if you're operating in a completely or very dry eye. So it really doesn't matter if it is unilateral, bilateral, or what kind of tissue transplantation you do. Even if you do a corneal transplant in a dry eye, that transplant will eventually fail either because of rejection or more commonly because of epithelial healing problems. Now, if you're dealing with a case of bilateral limbal stem cell deficiency, or if that is the only eye of the patient, then it's a completely different ballgame. Again, you take a decision on whether you're going for cell-based therapy or not, or limbal stem cell transplantation or not, based on whether the eye is wet. Like I explained before, the environment should not be hostile to tissue transplantation or cell-based therapy. And therefore, if the eye is wet, we can try a combination of allogeneic limbal stem cell therapy with or without keratoplasty, systemic immunosuppression, etc. But a more simple way to approach that, and this is usually the part that most people take nowadays, is to do a type 1 keratoprosthesis surgery in these patients rather than trying to go the more convoluted, complicated route of allogenic stem cell transplantation with immunosuppression, with or without keratoplasty. Now, the reason that I've written keratoplasty here, and previously I said that, when you're doing autologous limbal stem cell transplantation, then you don't want to combine that with the keratoplasty and you want to wait for spontaneous stromal clearing, is the fact that typically in bilateral limbal stem cell deficiency, the pathology is also complicated. Typically, you're looking at patients who have had bilateral chemical burns or Steven-Johnson syndrome or pemphigoid. And usually these patients will also have a lot of stromal scarring or stromal opacification, may even have added leukomas, etc. And usually they don't respond only to stem cell therapy. They will also need corneal transplantation. And therefore, and exactly for this reason, these patients do much better with a type 1 keratoprosthesis rather than a stem cell therapy. Now, if you have a dry eyes, it does not mean, again, unlike in unilateral cases where I said if it's dry, then we are not going to intervene surgically. We're just going to give the patient a cosmetic correction with contact lenses or prosthesis. When it is bilateral and dry, you don't have that luxury because this patient is bilaterally blind, unlike in unilateral patients where even if you, just improve the cosmesis, the patient may be happy even if the vision doesn't improve. In bilateral patients, the aim is to give the patient functional vision in at least one eye. So you can't just say that, okay, we are not going to intervene in patients with bilateral problem because they require functional vision. And therefore, in these cases, there is a more complicated option of doing what we call type 2 KPROs, the modified osteoodontokeratoprosthesis or the Boston type 2 keratoprosthesis. You also have the LVP keratoprosthesis or the more recent modification of the Boston type 2 called the Lux keratoprosthesis. The only exception is that if you have a bilateral limbal stem cell deficiency where there is also, in addition to being dry, uh, the patient also has nil visual prognosis in both eyes. In that is the only case in which you think of a cosmetic contact lens. There is one caveat, although over here, that I would like to mention, and which is that if you have a patient who has um, a bilateral corneal disease or blindness because of bilateral ocular surface or corneal disease, and the patient is very well adapted to their visual handicap, they do not otherwise feel that they have a disability, but when other people point out to them, but they are otherwise well adapted to their handicap, they are well educated, they have a job. I feel very reluctant in intervening in them surgically just to find out if there is visual potential or not. I think that's not a very good idea. It unnecessarily complicates their lives. And sometimes when things don't work out, these patients feel very disappointed, and you unnecessarily, you know, complicate their lives to the extent that, people were leading very functional, productive lives, and now they are visiting the hospital every day in and day out, and that is completely unnecessary. So do, in addition to just looking at the eye, also look at the patient while taking these decisions, and what exactly the patient wants versus what the patient needs is also a call that the treating physician sometimes has to make on his or her own. Having said that, I will say that there are certain exceptions where you can treat limbal stem cell deficiency or severe ocular surface disease without actually having to do a limbal stem cell transplantation. Like, for example, you have a partial limbal stem cell deficiency with severe symblepharon. Here you can see that the superior limbus looks pretty much normal. You can see the pigmented palisades here. Whereas from about 3 o'clock to right to 10 o'clock, you have this very vascularized pannus like a pseudopterygium growing over the corneal surface. This is a case that I would not treat with limbal stem cell transplantation at all, but just treat with a conjunctival autograft, just like you do for a primary pterygium. So if you have a pseudopterygium or a recurrent pterygium, you treat it exactly like a primary pterygium by doing conjunctival autograft. And that usually gives excellent outcome. This is the same patient 1 year following conjunctival autografting from the other eye. And you can see here that, the cornea is clear. There's no recurrence of symblepharon. This is a fantastic outcome without needing to transplant any limbus from the other eye or from the same eye. Because, the limbus in the superior cornea is enough to sustain the corneal surface. This is primarily a conjunctival problem, which needs to be treated by doing a conjunctival transplantation. So coming back to the algorithm that I showed you in this talk, because this is a very complex topic and it's very difficult to cover everything at one go. I will primarily focus on unilateral limbal stem cell deficiency, what you have on your left side, and tell you about autologous limbal stem cell transplantation. What are the surgical techniques? What are the indications? How do we actually go about it? Post-operative care and outcomes. The right side, which is bilateral limbal stem cell deficiency and which is mostly to do with keratoprosthesis, is really a more complex topic that requires a separate discussion. And it is really, out of the scope of this lecture. But I'll be happy to take any questions if you have. The first thing that you need to do when you're treating severe ocular surface disease due to limbal stem cell deficiency is to confirm the diagnosis of limbal stem cell deficiency. What you must remember is that any patient who shows up with a scarred and vascularized cornea or even an abnormal looking limbus does not necessarily have stem cell deficiency. So how do you know that this is stem cell deficiency? The easiest way to do it is to do a fluorescein staining and to look for stipple staining of the corneal surface as well as the conjunctival surface, like you see in this photograph. If you see that, that means that the epithelium that is covering the cornea is unhealthy and is probably of the conjunctival phenotype. And also look for superficial as well as deep scarring. Usually superficial scarring will be more in favor of conjunctivalization rather than deep scarring. So you can actually see deep scarring with vascularization in somebody with chronic, let's say herpes keratitis or herpetic keratitis, but in stem cell deficiency, post-chemical burn or SJS, etc., it will be more superficial, and you will have the stipple staining of the epithelium particularly on the corneal surface. You can also use imaging, like on the photograph in your top right. This is a confocal image which shows the type of epithelium on the ocular surface, and there are specific phenotypes for corneal and conjunctival epithelium, and you can look at the confocal images and make a determination if the epithelium on the cornea is of limbal lineage or corneal lineage or conjunctival lineage. The OCT is again, it's very, very useful in this regard. Even if you take a line scan of the cornea, central cornea, and if you see a epithelial surface which is hyper reflective or as reflective as the stroma or more reflective than the stroma, that indicates a epithelium of the conjunctival phenotype. Usually, typically in a normal cornea, the epithelium will be translucent or hyperreflective. and the stroma will be a little hyperreflective. But if this reverses and if you have a hyperreflective epithelium, that usually points, and you also the thickness, the normal corneal epithelial thickness is around 50-60 microns. So if that is above 100 microns, that also points towards conjunctivalization. OCT angiography, which is now available for the anterior segment of the limbal vasculature, also helps in differentiating. You don't see the normal epithelial loops that you see, but you see, this very dense vascularization at the limbus, and you can also do a segmentation just like you do for the retina to look at which level the vascularization is to make this diagnosis. And then, of course, on your bottom right, you have what is known as impression cytology. So you can take a filter paper, take some cells of the cornea, just like you do to diagnose OSSN, and you look at those cells from the filter paper under a microscope to find out, what phenotype they are. You can also do cytokeratin markers to see if they express corneal markers like CK3, CK12, or they express conjunctival markers like CK19 or MUC5AC. So it is important either by using simple clinical tests in your clinic, um, using fluorescein or lysamine green staining, or more advanced imaging like confocal or OCT or angiography, or diagnostic techniques, lab diagnostic techniques like impression cytology to confirm the diagnosis. So it is important because you don't want to be unnecessarily treating those cases which do not have limbal dysfunction but simply have corneal scarring and vascularization due to chronic inflammation, particularly due to herpetic keratitis. Because if you do treat them surgically, then the outcomes will be very unpredictable and in most cases unsatisfactory. So once you've confirmed the diagnosis that this is a case of limbal stem cell deficiency, we think about doing a limbal stem cell transplantation. Limbal stem cell transplantation has been around for almost 30 years. It has a very high degree of success if the right case is chosen, and there are at least 3 techniques of stem cell transplantation which are in vogue. The ex vivo cultivated limbal epithelial transplantation, or CLET, is the most sophisticated technique, which makes use of a cell culture facility or lab. You also have the conjunctival limbal autografting, which is the original technique that was described by Professor Kenyon and Sheffer Singh in 1989. And we have the most recent modification or innovation in this field called the simple limbal epithelial transplantation, or SLED, which we developed at the LV Prasad Institute. Originally, actually, at LVPI, we started off many years ago under Dr. Sangwan's leadership. We were at that point of time in the early 2000s performing cultivated limbal epithelial transplantation, or CLET. And we have, extensively done this procedure in over 1,000 individuals and published the outcomes. And the outcomes are actually pretty satisfactory. You have a success rate of between 75 to 80% in adults and about 50 to 60% in children. And we actually used to do this procedure until about 2012, 2013. What happens in this is you take a biopsy of the limbus, and I'll show you how the biopsy is taken. It's the same procedure for whether it is CLET or SLED. And then you cut the biopsy into small pieces and put it on an amniotic membrane graft, and the limbal epithelial cells just kind of crawl out. So you can see here on your top left in this photograph, at the edge of the limbal explant, you see these small cells basically crawling out of the explant onto the amniotic membrane and forming a monolayer of cells. And you can get a multi-layered epithelium also, and you basically transplant that on the corneal surface. And as you can see on the series of photographs at the bottom row, this is a patient with limbal stem cell deficiency, superficial vascularization scarring. Immediately after surgery, you see the amniotic membrane. You can't actually see the cells, but if you see over time, and this is at 1 year of follow-up, you see how nicely the corneal clarity has improved, the epithelial luster has improved, and it is stable, and there is no more vascularization or scarring of the cornea. And this is typically what you would see in an outcome. The only problem with cell cultivation was the logistics. And in the Indian scenario particularly, it was quite a challenge because the patient would have to come for the first procedure, which is a biopsy, and then would have to essentially wait till the cells were ready to be transplanted. And that made it a little bit of a problem. And sometimes you had to time the transplantation. It was very critical because you had to time it just right when you had enough cells, but not too many. So you do not have the cells overrunning your culture plate and becoming fibroblasts, but you had just had enough. And if the patient wasn't able to come back specifically at that point of time, then the culture would just go waste. You have to take another biopsy, and it was obviously more expensive for the patient because there were two separate procedures, and because it's cell cultivated, you have to maintain a cell cultivation lab. And now, under the current regulations and guidelines, these labs have to be good manufacturing practice compliant, or GMP grade labs, which are very, very expensive to set up, and even more expensive to actually maintain and sustain. So those are the challenges that you face with CLED, and this is the same the world over. So we moved on to a technique called simple limbal epithelial transplantation beginning 2010. The rationale of SLED has a lot of parallels in dermatology. And I would particularly like to point out these two procedures. The first is called the Meek procedure, which is used for the treatment of severe burns, and also the melanocyte transfer technique, which is used for the treatment of vitiligo. So what happens in the Meek procedure is you have a patient who has extensive burns covering most of the body, and obviously you can't harvest a skin graft from the same patient of the same size. So basically you take a smaller graft and you cut that into pieces, and you distribute the small pieces over the entire denuded area. So you can see here these small pieces of skin grafts and empty spaces in between. So basically it's a fill in the blank technique. You put these small grafts, and the stem cells will produce more epithelial cell, which will grow out of these small graft and fill in the blanks. And the epithelium will just spread and fill those empty spaces in between. Similarly, for patients with vitiligo or depigmentation, you take skin from a similarly pigmented part of the body, distribute those pieces in that depigmented part, and the epithelium along will carry the pigment with it as it grows out, and kind of, again, fill in the gaps, fill in the blanks, and kind of spread the pigment in that area as a treatment for that. So SLED conceptually, principally, is essentially the same concept, where instead of putting a large graft or taking the entire epithelium like you do in CLET, you have an entire sheet of epithelium that you put over the entire cornea. You basically just put small pieces of the limbus distributed over the cornea. And these pieces have enough regenerative potential to produce hundreds of thousands of lines of epithelial cells, which then grow out and epithelialize the cornea, stratify as they go on, and restore a normal, transparent, epithelialized and stable surface over time. We have actually shown this in a couple of publications. The first was by Vikas Mittal and Rajat Jain from New Delhi and Chandigarh, Ambala, where they showed how the negative staining actually progresses over time. And if you read a recent review article in the Indian Journal of Ophthalmology, which was published in, I think, August of last year meaning 2019. So now, there's one more year which has gone by in between. You will actually see the same images, which explains this very beautifully. So on the first day, you have, you see these small pieces, and which are not staining. You see, the negative staining here because these pieces themselves are epithelialized. But over time, you see these islands of negative staining growing out of the individual pieces, and slowly these islands join together to form larger land masses, kind of, and then continents. And at the end of usually 7 to 10 days, you have confluent epithelium all over the surface. And you see the same thing on the OCT scans. And there is a recent case report that you can look up in BMJ, which actually shows the serial OCT scans in a patient from before surgery, first day post-op, to about 4 years of follow-up, which also shows this very beautifully. And so what you see basically after the initial few days of the transplant is epithelium growing from the edge of each of these limbal pieces, and then forming a contiguous sheet which joins two individual separate pieces. and then forming a multi-layered stratified epithelium, which is very even. And you can even see the highly reflective amniotic membrane on which these cells are. So what are the ideal indications for SLED? Now, when I say ideal indications for SLED, I also want to make the point that these are ideal indications for any form of limbal stem cell transplantation, irrespective of the technique, whether you're doing conjunctival limbal autografting or cultivated limbal epithelial transplantation. I'm sure that all of you who are listening to this lecture, none of you have access to a stem cell lab. So CLET kind of becomes a theoretical option in that case. And we are mostly looking at choosing between CLET and conjunctival autografting. And I will tell you at the end which are the situations in which conjunctival limbal autografting actually, I feel at least, is more advantageous than SLED. But I think otherwise, for most of the cases, you will be able to restore or at least provide good outcomes with SLED. So first, like I mentioned before, the first criteria is that it should be a confirmed case of limbal epithelial stem cell deficiency, which you can confirm by doing fluorescence staining or using corneal imaging techniques like I discussed in the previous slide. It should be a wet eye. I also mentioned this before, and one of the ways of picking that up easily is by just looking for conjunctival xerosis or keratinization. And of course, you can do a Schirmer's test to rule dryness out or to get a relative idea of how dry the eye is. The patient also should have, or the eye in which you're about to operate, or should also have a relatively clear corneal stroma. I mean, when I say relatively clear, I mean that there should be some potential for corneal clarity. It should not be a completely white cornea. It should not be an adherent glaucoma, etc. So the anterior segment should not be disorganized. It should not be a case where even the endothelium is dysfunctional, etc. There should ideally be either no adnexal damage, or the adnexal damage, which is either an entropion or lack of thalamus and ectropion, should have been corrected before attempting limbal stem cell transplant. Preferably unilateral, preferably total or complete LSCD, like I mentioned with the example of the pseudopterygium in the beginning, that it is only in total limbal stem cell deficiency that you think about doing limbal stem cell transplantation. If it's subtotal, you might actually get away with just by doing a conjunctival autograft. Treat a pseudopterygium like a pterygium. Preferably cases that are alkali burns. Acid burns typically have more adnexal damage, and that's why this point. They also typically have more corneal scarring and would also require a corneal transplant. And those preferably without severe symblepharon. If you have a severe symblepharon, then you need to combine it with a conjunctival autograft. If you do not combine it with a conjunctival autograft, then there is a very high likelihood that the symblepharon will recur, and the benefit of the surgery will be lost. So if you look at this, these 8 cases that I have arranged here for you, the question on the left side is, which of these cases would you feel are suitable for SLED, where the outcome is good and which meet the criteria that I described above? So not all of them do. 4 of them meet the criteria, and 4 of them don't. So if you look now, after rearranging these cases a little bit, those on top, these are cases with total limbal stem cell deficiency, where in some cases, some part of the pupil is visible, so you know that the corneal stromal clarity, some clarity is there. It's a wet eye that has some luster. There is no significant symblepharon, entropion, ectropion, lack of thalamus in these cases. Where in the cases at the bottom are those which are which have lid abnormalities. There's an adherent glaucoma here. There's a dry eye, severe dry eye, stromal thinning, symblepharon, uncorrected entropion, dry eye, keratinization, etc. So the bottom row, these are cases that are, if unilateral, I would not touch unless this was the only eye with visual potential. If bilateral, these are cases that would require a keratoprosthesis. Now, in this case, in the next case, and also the last case, you would have to do a type 2 keratoprosthesis because of the dryness, whereas in this case, you might get away with a type 1 keratoprosthesis, like I described in the algorithm in the beginning. Top row, of course, these are the cases that are ideal for SLED. Now, I'll just quickly show you the surgical technique. I'm sure that many of you have already seen it or are aware of what we do. First, we take a limbal biopsy. Here, I'm just marking the conjunctiva next to the limbus, not marking the limbus directly because the alcohol in these skin markers can damage the epithelial cells. We usually mark about 1 clock hour. We lift a limbus-based conjunctival flap. This is just so that we have a good handle and we can dissect easily. We go from the conjunctival to the limbal side, a very careful dissection of the limbal tissue. And then we cut the conjunctival part off. If you're doing a conjunctival autograft also, you use this, otherwise you just discard it. And then we take the limbal tissue separately. And this is just 1 clock hour of pure limbus, no conjunctival. This is followed then moving to the eye that is damaged. Like I mentioned before, these are unilateral cases and we're doing an autologous transplant from the other eye of the same patient. We do a 360-degree peritomy and a combination of blunt and sharp dissection to remove the vascularized thick conjunctival pannus from the corneal surface and a little bit of cleaning up, after which we put the fresh preserved human amniotic membrane. These important here that it's not a dry lyophilized membrane, not a freeze-dried membrane, but a fresh frozen amniotic membrane graft that we glue onto the entire ocular surface. And after the amniotic membrane has been glued onto the surface, I'll just go back. After the amniotic membrane has been glued onto the ocular surface, then we start the limbal transplantation procedure. Usually there is a bit of a redundant edge of the amniotic membrane that kind of folds up beyond the margins of the conjunctiva, which you can trim nicely so that you know that the conjunctiva amniotic membrane is nicely tucked in 360. And then we take the limbal graft and we cut it into small pieces. Typically, this is a 1 clock hour graft, which is about 3 to 4 millimeters in length. And you can make about 6 to 8 pieces without making them too small or leaving them too big. And we distribute them in a circular fashion in the mid periphery of the cornea and put a drop of the first component of the glue, which is the fibrinogen, distribute that on the surface with a blunt spatula like iris depositor. And then we put the second component, just a little bit, one tiny drop on each piece, and then center, wait for it to gel. You can see this white powdery kind of formation, and then put a bandage, soft bandage contact lens at the end. So it's a completely sutureless procedure. And of course you use fibrin glue, which disintegrates with time. And this is the typical post-operative course. So on your left, you see the total LSCD, conjunctivalization, etc. And then at 1 week, you see these individual pieces. This is on 1 day. So you see the fibrin glue and the air bubbles trapped in the fibrin glue. And usually at 1 month, the membrane degrading a bit, the corneal clarity being restored. Some cases, you might see some, a little bit of hemorrhage under the amniotic membrane, so some blood that is still visible. But usually by 6 weeks or 3 months, this is completely gone, and the corneal clarity is completely restored. And you see over time that there is no recurrence of the vascularization or the conjunctivalization on the corneal surface, and the patients usually recover good vision. And you can give them, if there is irregularity of the corneal surface, you can give them contact lenses. Or, in many cases, actually, if the cornea is that clear, if the stroma is that clear, you can even give them just a spectacle correction. Now, if you look at the evidence, which has, been presented in a lot of studies that have been done now across the world, the largest series, of course, is from LVPI, which was published in Ophthalmology in 2016. But if you also look at the multicentric study, which looked at outcomes from various studies, various countries, including India and other countries in North America, the United States, Mexico, and other centers in India, and other follow-up studies which have been done. The interesting thing about all of these large studies that have been, and now there are more, I'm kind of presenting data from about a year ago. What is interesting is that if you look at the Kaplan-Meier survival curves in all of these studies, they are remarkably similar, and they show that it is effective in close to 80% of cases of autologous unilateral limbal stem cell deficiency where autologous transplants are being done. And there's a recent meta-analysis which has come out, which has shown that in these indications, Sled actually is more effective than cultivated limbal epithelial transplantation, particularly in children, and its efficacy is comparable to the original technique of conjunctival limbal autograft, which actually takes 3 or 4 clock hours, which basically challenges the paradigm of how much limbus is required to sustain the ocular surface. And it looks like 1 clock hour might be enough. And if you can achieve good outcomes with 1 clock hour, why do we unnecessarily need to use more radical techniques like conjunctival autografting where you're using more than that? So if you look at the evidence, and this is pretty much established now, that the advantages of Sled are that it does not require a stem cell lab. Obviously, that logistically makes it easier for the patient. One procedure, less expensive, obviously more affordable. Because you're taking a very small amount of donor tissue, there is no risk of any limbal stem cell deficiency in the donor eye, which is a serious problem with conjunctival limbal autografting, particularly in beginners, because you're working with between 4 to 6 clock hours of tissue that you're taking. So there's no, if it fails, that's it. You can't take any more tissue from the donor eye again. Instead, potentially, if it, if you go wrong once, you can go back and take another biopsy. And the outcomes, and these are well established now, very, very consistent outcomes, both in adults and children, close to 80%, which I said, like I said, is dramatically more than you see in CLED and compared to what you see in cloud. The only problem with congenital autografting is that there are very limited studies from about 20, 25, or at least 15 years ago. And most of them are in adults. We have very little information of what the outcomes are in children. And I would say that most corneal surgeons today would hesitate in doing a radical surgery like congenital autograft in children. Unfortunately, in India, a lot of these cases with severe ocular surface disease or limbal stem cell deficiency are children, and therefore SLET really, hits the bullseye and for these patients, because it is such a safe procedure for the donor eye. You don't really feel that you are putting the patient at risk at all. I will also like to mention before I finish what the limitations of SLET are. I think that there are certain situations where I would prefer doing a conjunctival limbal autografting. I don't do a traditional conjunctival autograft. What I do is called a mini CLAU, and I'll explain what that is. So in patients with who have limbal stem cell deficiency with opaque stroma, and I said this is one of the contraindications that you would try to avoid SLET in these cases, or those patients with subtotal LSCD with severe symblepharon. And again, I mentioned this early on in the beginning that in many cases you can get away with the conjunctival autograft alone. You won't even need limbus. But in patients who have opaque stroma and LSCD, I prefer doing a conjunctival limbal autograft, a mini conjunctival autograft with a lamellar or a full thickness keratoplasty. The reason that I don't prefer doing SLET in these cases is that although you will restore the ocular surface, because it is still a vascularized cornea and it is still a high risk graft, your corneal graft may fail in the future. So the PK or the LK that you have done, there might be interface vascularization, there might be endothelial rejection if you don't have PK, and it remains at high risk irrespective of how well you've restored the surface. But the problem is when you replace the graft, when you do a repeat PK, the SLED transplants that you've placed in the mid periphery will be replaced, will be lost along with the graft that you will excise. So if you do a conjunctival limbal autograft in these cases, then that is at the anatomical position of the limbus, so you can do a smaller graft and retain the original limbus that you transplanted. The only difference, like I said, I do a mini clow and not a clow, where the conjunctival component is about 3 to 4 clock hours, but the limbal component is only about 1 clock hour. So in this particular case, you can see this vascularization here. That's the limbal component. It's only about 1 clock. And in subtotal LSCD, where there is severe symblepharon, and if you do not really find any healthy looking limbus, if you find healthy looking limbus, you can, like I said in the beginning, you can get away with just conjunctival autografting. But if you can't find healthy looking limbus, then you might want to do a conjunctival limbal autograft. And you want to take a little bit of limbus along with your conjunctival autograft tissue. And that usually does a very good job, because this is a combined, what you have to understand in case of a severe symblepharon is that it's a combined limbal and conjunctival deficiency, which is best treated with a combined limbal and conjunctival graft. So doing just SLED, which is only limbal transplantation, is not. You can of course treat these cases with SLED and a conjunctival autograft, but just doing a CLAU is much more simpler in these cases. You don't need an amniotic membrane. It's a shorter procedure. You don't need fibrin glue and so on and so on. Now, I'll show you a couple of cases, and this will demonstrate to you in a very in a snapshot what the potential of this surgical technique is in terms of efficacy, not only in restoring the surface, but also restoring corneal clarity. So this is a patient that I operated in almost 9 years ago. That's July 2011, and the patient had visions of hand motions, of light perception at the time that we did the surgery. He's a young adult. He was, I think, about 20 years of age when we did the surgery. And I remember that when I was doing this and I excised the panels and I was about to do the sled, I mentioned to my fellow, and I remember that Jayesh Vazirani, who is now a very successful ocular surface specialist in corneal surgeon in Ahmedabad, he was my fellow at that time. And I mentioned to Jayesh that, you should put it down in the notes that this patient has a very scarred and vascularized corneal stroma and may not recover very good vision. And as I had predicted, when the patient came for follow-up 6 weeks later, in August of 2011, you can see here that the surface is nicely restored, but there's so much of scarring, irregularity, vascularization that is still there. You can see all these ghost vessels in the cornea. And the patient had about 2400 vision, and I thought that that was the best that the patient was going to see, and I would give the patient contact lenses later on. Lo and behold, when the patient came back in March of 2012, which is about 9 months from surgery, the vision had improved to 21, 25. And you can see that the corneal stromal clarity has improved a little bit. There's still significant amount of corneal haze and vessels here in the temporal cornea. Uh, in 2014, most of that was gone. The lipid keratopathy was gone. The ghost vessels had regressed. The corneal stroma looked much clearer. In 2015, it was a little bit more clear. The vision had improved to 2060. And this is all unaided vision. And when the patient came for his last follow-up in June of 2018, the patient had an unaided vision of 2040. And this is all without, topical corticosteroids. This is, I'm just saying, natural progression or improvement of corneal stromal clarity. So there seems to be some amount of stromal remodeling that also occurs in these patients, which leads to a gradual and progressive improvement in corneal stromal clarity and regularization over time. I unfortunately don't have the serial topography in this case. I wish I had done it. But I think that would also have shown that the corneal topography regularity also had been improving with time. So like I said I said in the beginning that in those patients with unilateral LSCD, don't jump to doing a corneal transplant at the beginning. Just try to restore their surface and wait for the spontaneous stromal clearing, because it will happen in a significant number of cases. And just to finish with this last kind of case study, this was a 12-year-old boy who his uncle had brought him from a small village in Maharashtra, very bad tuna injury with a ugly looking granuloma on the surface. And they had actually come for seeking cosmetic correction. And possibly if we could, they basically wanted the eye to be removed and replaced by an artificial eye. And I said, we can actually treat this by doing stem cell transplant from the other eye, by doing a Sled. And these were still early days. This is 2011, 2012, early days of Sled. And sometimes, like I mentioned, you're going to take you're going to treat the affected eye, you want to take a biopsy from the good eye. So it's not surprising that sometimes the patients or relatives of the patient themselves are reluctant for their good eye to be touched. But you need to have that discussion with them and communicate to them clearly why that is important and how it is safe. So it's also important to learn the procedure of the limbal biopsy as well as the limbal transplantation, so that at all times you are confident and you're sure that you are not doing any harm to the patient. If at all, the patient will benefit from what you're about to do. So in this patient, we did the SLED procedure in 2012, and this patient last visited us in 2018, I think January, when we had the SLED workshop. And now he's, when I last saw him, he was 18 years old. And this is the photograph of his eye, how it looked when he had first come to me, which is holding, the iPad in front of him. And this is what it looks like now. And this was his left eye, which had undergone surgery. If you look at him now, there's no way that you would be able to tell that he had such a, huge granuloma on his surface or just such severe or extensive limbal stem cell deficiency or ocular surface disease in the eye. He's done so well, and he's a living testimony to um, uh, uh, the efficacy of Sled. Like I said, not only in restoring the ocular surface but also improving corneal clarity. He is, in fact, his uncle informed me last year that he has actually enrolled in an MBBS course in Maharashtra and is training to become a doctor. And this last case here, similar vascularization, scarring, and this is the post-operative outcome. Now, if I showed you this photograph before I showed you what it looked like pre-operatively, you wouldn't, it would, you would struggle to find out what is wrong with this eye. I mean, you can see a little bit of vascularization and scarring here superiorly. But this is how effective Sled can be in improving a cornea that is, or at least the ocular surface that is damaged by severe injury due to corneal burns, or even more complicated causes like SS or pemphigoid. But in those cases, you're doing an allogenic graft because usually the conditions are bilateral. Now, again, as I mentioned before, I'm not going to go into bilateral LSCD because it's a discussion for a separate day. To summarize what I have just talked about and explained to you, if you're seeing a patient autologous, if you're planning to do an autologous Sled in a patient with unilateral limbal stem cell deficiency, like I mentioned, you're obviously planning that because the patient has wet eyes. You're not doing that if the patient's eye is dry, the stroma is severely damaged, patient has added glaucoma, or the patient has uncorrected adnexal damage. Those are things that you need to take care of. We know very well from our experience, from the experience of other surgeons, a lot of literature that is now available, that it's effective, it's a replicable, affordable, and reliable procedure. Um, and typically for chemical burn-induced unilateral LSCD with wet surface, normal irids, and no exposure, it's a very, very safe and effective procedure. And if you're planning on, if you still have second thoughts and you're thinking of, okay, what is the technique of LSCD that I am going to do in these cases? And like I said, if you are in case selection is proper, irrespective of the technique, you will probably have in excess of 80% chances of success. In our experience currently, now that we are, we are wiser than we were 10 years ago, the success rate in our hands is in excess of 90%. Probably close to 100%. But if you do not have an access to a cell culture facility, which very few centers in India and very few centers across the world have, then basically your choices are between a CLAU and a Sled. And I'll say that unless you're dealing with very complex reconstruction, which needs addressing a symblepharon or addressing a stromal opacity using penetrating or lamellar graft, you're basically looking at Sled. So Sled this is where 90% of your cases will be. This is where about 10% of your cases will be. And none of you will be doing Sled because nobody has a cell culture facility or nobody has approval from the regulatory authorities to do that. It's an extremely, I mean, we have a GMP certified cell culture facility, and even we struggle to get approval for cell-based therapy using various forms of stem cells. So thank you very much for listening in, and I hope that I have been able to provide some clarity. It's a very difficult topic, not really discussed at length very often, and if you have questions, which I'm sure you'll have, please feel free to ask or reach out to me on you can reach me on my email and ask those questions. I'll be happy to answer. Thank you.
Thank you very much, sir. That was a really, really wonderful lecture, and the pictures and videos were just amazing. So, in fact, we don't really have too many questions because you cleared most of the things very well. We'll just take a couple of them. One is, what is the post-operative routine that we follow after the surgery, after SLED?
So usually you're doing an autologous graft, and you just give the patient topical medications to control or just mitigate the little bit of inflammation that is there on the surface. Topical because there is usually surgical handling, and there will be some inflammation to control that doesn't go out of hand. You don't end up with granulomas, etc. and for a short period of time. So usually about 4 to 6 weeks in tapering doses, usually the same taper that you would give for a routine cataract surgery, 4 to 6 week taper of Predfor starting from 6 times a day to once a day. And after that, you stop. You really don't need to give them topical steroids beyond that because, as I said, autologous graft, there's no risk of rejection, etc. If you are doing it for bilateral, if you've taken the limbus from cadaver or another living donor, then it's a different story. Then you need to give them some immunosuppression over time. You can either do that topically. The problem with continuous topical or high dose topical immunosuppression is that you can have there is risk of developing glaucoma or cataracts, which are not impossible to manage, but you want to avoid that. So the easier way there would be giving systemic immunosuppression. Systemic immunosuppression has other issues in terms of compliance and price and affordability and things like that. Monitoring is required. So otherwise, like I said, if it's autologous, if it's for a unilateral case, then the medications are just for 4 to 6 weeks post surgery. You of course give it in both eyes because you've also taken a biopsy from the good eye. So some people, I think, sometimes forget to give the steroids in the eye that has been biopsied, where the donor tissue has been taken from, and that can sometimes lead to granuloma. Not difficult to treat. You can just give them subconjunctival steroids or topical steroids, and that takes care of it. But unnecessary, completely avoidable. So that's basically it. I mean, unilateral, autologous, topical, uh, bilateral, allogenic, systemic.
All right, sir. And sir, the second question is, if we do have access to the laboratory, are there any conditions where you would choose to do CLET rather than SLET?
That's an interesting question. So I think that for most routine cases, no, but I think that CLET has a role in certain exceptional cases. Let's say, for example, those patients who have stem cell deficiency due to a genetic disorder. Okay, let's say like epidermolysis bullosa. Now, epidermolysis bullosa is rare, extremely rare, but it's also, it affects children. It is a very severe form of stem cell deficiency. And in those cases, it's almost unthinkable to do very extensive surgery. Um, in those cases, if you can actually combine a cultivated transplant, or you take limbal cells or from the patient themselves, and then you can do a genetic manipulation like a CRISPR in the lab and then correct that and put them back, that would be fantastic. In fact, it has been done. Both allogenic of course has been done, cultivated transplant for epidermolysis bullosa, but even um, um, genetic correction or gene therapy by using CRISPR for correcting the defect and then cultivating those cells and putting them back. So you have a double advantage. You are using autologous cells in that sense that won't reject, and you also fix the genetic mutation because of which the patients have this congenital problem, and it's usually very severe. So Graziella Pellegrini, who was instrumental in developing CLET, she works out of Rome in Italy, and she has a series that she's treated with this kind of an approach for epidermolysis bullosa. So I think that is definitely an area where CLET would score over other techniques. And also in cases where, let's say, you have a very tiny amount of normal limbus, not even enough for Sled, and you want to treat either one or both eyes, and I think their expansion of stem cells would help. Like you have only half a clock hour of intact tissue, you can take that, grow it in the lab, make it into many clock hours of tissue, and then transplant it back into one or both eyes of the patient. That also in fact has been reported, and that I think is also an indication where CLET would score, because you would not have enough tissue to do a tissue transplant like SLET or CLA.
All right, sir. Thank you. And okay, the third question is there any role of doxycycline in these patients with limbal stem cell deficiency?
Doxycycline per se, I think definitely has a role in patients who have chronic inflammation as an anti-inflammatory. I think um, um, doxycycline in would have a similar role in limbal stem cell therapy or limbal stem cell deficiency as hydroxychloroquine would have in COVID. So, it definitely has anti-inflammatory action. I don't think that it would make too much of a difference, but I think that in those cases that have very early, like patients with contact lens induced corneal vascularization, etc., where there's a little bit of inflammation because of meibomian gland dysfunction as well, and you want to take care of those things, there might be. But in case that have severe, advanced, developed forms of stem cell deficiency, I don't think doxycycline is going to make a difference.
Okay. So one last question. Although this was not part of this topic, but one of the hot seat participants wanted to know what is the indication for type 1 and type 2 keratoprosthesis?
Okay, so there are various kinds. First of all, you have to understand that there are, at least at this point of time, or this point of time in history, there are close to 250 different designs of keratoprosthesis which have been described. In fact, the history of keratoprosthesis dates back to far longer than the history of keratoplasty. So again, probably a topic for a different day.
Yes.
But of the various types of keratoprosthesis that have been described, at least there are 9 or 10 types which are currently being implanted across the world, of which the Boston type 1 keratoprosthesis is the most popular. And we have a version of the Boston type 1 keratoprosthesis called the oro keratoprosthesis, which is available for our lab, and quite inexpensive compared to the Boston Kipro. So the type 1 keratoprosthesis, initially when they designed the keratoprosthesis and when they were implanting it in patients, they were doing that for all kinds of patients with LSCD. But over a period of time, they realized that it was really more effective in patients who did not have severe ocular surface disease. So it did not really work that well in patients with dry ocular surfaces with SJS or OCP or other kind of immunological problems, and it worked best in patients with either, let's say, multiple field grafts or multiple surgeries or straightforward limbal stem cell deficiency. So type 1 keratoprosthesis is an alternative to a allogenic stem cell transplant. So the same indications that you would do for an allogenic stem cell transplant, not too many adnexal problems, wet eye, conjunctivalized surface, anterior segment is not badly disorganized, etc. But it's a much more straightforward, simpler way of doing it, and it gives good results in the medium to short term. Retention, of course, is an issue. And the type 2 keratoprostheses are those which are intended for patients who have much more severe forms of limbal stem cell deficiency. And there, you can't do a type 1 because the surface is dry or inflamed and it would melt over time, etc. So usually you do it under a skin graft or a mucous membrane graft. And you expose the optical cylinder of the K-Pro through that. So that's basically what a type 2 K-Pro is. And there are many forms of a type 2 K-Pro. The MOKP is the one that has been done most, I think. And then you have the Boston type 2. We have a modification called the LBP K-Pro and the other designs. So in Shankar Nethralaya, they do the MOKP. We do the LBP K-Pro. If you go to Boston, they do the Boston type 2. If you went to Amritsar, they would do the Singh type 2 keratoprosthesis. So there are various designs of the type 2.
All right, sir. Thank you so much for taking your time out on the new year and taking this class for us. It was a wonderful lecture. And thank you, everyone, for joining us today.
Thank you so much, Mritika and Ankita. And it was a pleasure talking to all of you. And again, let me just conclude by wishing all of you a happy new year full of good health and prosperity. Thank you.
Thank you, sir.